I'll be presenting two abstracts today. One regarding surgery, something based on surgery, and the other one is something that was being discussed in the earlier panel. What is residual disease? Minimal residual disease was something that was mentioned, and how that can be scored. Coming to the first abstract, this was a paper published in JCO in July 2019. The authors looked to find the usefulness of lymphoscintigraphy prior to doing a sentinel node biopsy in early breast cancer, the SENSI trial. Sentinel node biopsy, as we know, is now the standard of care for early breast cancer. There is no more a role for doing an axillary lymph node dissection upfront. Patients who have a clinically T1 to T2 tumor, and now also T3 has come into the purview. However, that is a little bit controversial. Patients who have a large DCIS or a palpable DCIS who are undergoing a mastectomy. Patients who are clinically N0, obviously. This also now includes patients who undergo imaging or a biopsy which is added from the axillary lymph nodes. And so the questionable role of lymphoscintigraphy comes in, that does it really add anything to performing a sentinel lymph node biopsy today? The inclusion criteria of this study was the same as the indications for doing a sentinel lymph node biopsy, because it just basically analyzed two groups of the same. The exclusion criteria were again exclusions for doing a sentinel lymph node. Along with that, they did have some particular aspects, recurrent breast cancer, having a prior breast surgery or axillary surgery. These were contraindications, or these were exclusion criteria in this particular study. The statistical analysis was made to be a non-inferiority study. They used a 95% confidence interval stratified according to the focality as well as the trial site to the multi-center study. They put the number at 0.21. This is the minus 0.21 would be the number of lymph nodes which would be different in the two arms. So coming to the basic meaning of that is the patients who underwent the sentinel lymph node biopsy without lymphoscintigraphy, and the number of lymph nodes which were harvested in the sentinel lymph node biopsy. And if you see the difference between those who underwent the lymphoscintigraphy prior to the sentinel lymph node, the difference should not be more than minus 0.27. That is the study calculation, and it was powered at 80. The primary endpoint of this study was the number of histologically detected sentinel lymph nodes per patient. The secondary endpoint was the number of node positive disease that was detected by a sentinel lymph node biopsy performed in each arm. The recruitment was across multiple centers in Germany and Switzerland between May 2014 and October 2015. They used a modified intention to treat population because there were a few changes in their after their screen failures. Mainly the methods were that the surgeons who performed the sentinel lymph node biopsy without lymphoscintigraphy were blinded to the data of the lymphoscintigraphy. This was not that it was not done. The lymphoscintigraphy was carried out for all patients, and the data was collected by the trial coordinators. However, the surgeons in the arm, one of the arms, were blinded to this data. This is the consort diagram. So the number of patient screens were 1210. They were randomly assigned to known data of the lymphoscintigraphy and the unknown arm. There were some patients who again dropped out due to certain reasons, and then it became a modified intention to treat analysis. So the final number was 1163. Each arm totally received 585 and 578 patients to be exact. So in the primary endpoint, when we come to the results, there was hardly any difference. The mean lymph nodes dissected was 2.21 in the patients who had a lymphoscintigraphy known to the surgeon, and those who didn't know it, it was 2.21. So there was a 0.05 difference in the number of lymph nodes when you come to the mean. They did demonstrate non-inferiority because the difference was 0.18 in the confidence interval. The secondary endpoint, which the number of lymph nodes which are positive on sentinel node biopsy, were again similar. There was no difference in this number, 22.1 and 21.6. Coming to the univariate analysis of the factors which would possibly have modified this particular outcome. So one of them could be the site of injection of the cradiocolloid. The other one could be the day of injection. We know that it is injected either the day prior or the same day. Some of them were performed with the addition of blue dye, but the majority were performed only singularly with radiocolloid and not with the addition of blue dye. Again, intraoperative fluorescence section determining the outcome, intraoperative fluorescence section not being there, and the patient is being subject to a second surgery for axillary lymph node clearance. All these factors basically were found to be non-significant in the two arms, and it did not change anything knowing the lymphoscintigraphy findings before. So the discussion was that accuracy of radiotracer guided sentinel lymph node is not inferior if you don't have the previous lymphoscintigraphy findings. The surgeons were all able to find at least one sentinel lymph node via the gamma probe in almost 99% patients. This is an excellent value which is achievable only with experienced surgeons actually, but however this study did manage to get this number. They used the number of sentinel lymph nodes resected as a surrogate to the false negative rate which we discuss when we come to sentinel lymph node biopsies, because at the moment doing an axillary lymph node clearance when the sentinel lymph node biopsy is not done, or it is there is some controversial finding, is not at all acceptable. Sentinel lymph node biopsy being negative, nobody proceeds to a clearance. This is again a forest plot just to show the univariate analysis. Everything is along the line of unity more or less. So they also had a point to make that potential bias of those who were blinded to the lymphoscintigraphy arm, as in the surgeons who were blinded, basically they might be little afraid that they might not pick up enough nodes, so they thought that they could pick up non-sentinel nodes in a larger amount, and that could lead to the axillary morbidity. However, this was, though this was there, that the surgeons did pick up a fewer number of lymph nodes which were non-sentinel, this did not add anything to the number of sentinels really being picked up. So the number of sentinel nodes in both arms remained the same, and the lymph node positivity as well remained the same in both arms. The surgeons capable of finding a lymph node in the absence of a node picked up on the lymphoscintigraphy also remained the same. So in spite of the lymphoscintigraphy not picking up a lymph node in the axilla on the imaging, the surgeons with the gamma probe were good enough to do it on table. So the conclusion remains that the sentinel lymph node biopsy is good enough, and it can be done by the surgeon on table without the information of a lymphoscintigraphy. Where does this help? It basically helps in the logistics. It reduces the cost for the patient. It reduces the hospital admission. It makes things a little simpler. So this is basically a time saving, cost saving procedure which can be probably avoided. Coming to the second abstract, this was presented in the San Antonio conference in 2019. This is an important score that has currently been developed by the MD Anderson group. It's residual cancer burden after neoadjuvant therapy, and they did a multi-center pooled analysis for the long-term survival outcomes in breast cancer patients. So we have come across quite a few scoring systems now with the new treatments being available, such as the TDM1 in the Catherine study, oral capecitabine in the CREATE-X study. So we know now that residual disease can be treated, and those who are treated for it will probably do better and they will survive longer. So we are now developing scoring systems to find out what is the burden of residual disease after neoadjuvant therapy. So the residual cancer burden score is a score basically which includes 5 parameters, which is first is the tumor bed area, which is the in centimeters or millimeters, the cellularity of that particular tumor bed, the percentage of cancer that is in situ disease, what is left behind as DCIS, lymph nodes, the number of positive lymph nodes, and the diameter of the largest metastasis. So this is something that takes into account the size of the metastasis in the lymph node, coming to the question that Dr. Shahina probably raised, that what is our isolated tumor cells only remaining behind. So this can probably score it, and now it can give a prognostic score to the patient. So you get a score according to residual cancer burden, and you get a class. So the classes are basically RCB 0 to 3. So 0 means a PATCR, so the patient doesn't have any residual disease. 1, 2 and 3 are graded according to the pathological findings. They do have an extensive section on their website which allows pathologists to actually go through and compare their findings to the instructions given by the pathologists in this scoring system. So as a comparison, they can utilize the instructions and come to a score on the final histopathology. Their inclusion criteria were basically all the data that they could pick up from 10 institutes around the world. Their analysis was quite complex. They did a mixed pool analysis, they did a multivariate analysis, mixed effect Cox models with the incorporation of coefficients for the RCB to omit the heterogeneity between different trials. However, the trials did have different data, they did have a lot of variances. They tried to possibly match everything down to get a single score for each study. The number that they started with was 5,328 due to various reasons. Final pool analysis was coming down to 5,161 patients. The summary said basically that the EFS and DRFS data which was in these studies correlated extremely well with the RCB score. So this is what the RCB score looked like when they put it together, and they saw that the RCB 1, 2 and 3, the patients, how they did in the survival. This is coming to the overall population. You can see the curves separating very nicely. The first one is the blue one, that is the PATH-CR, and the last one is the RCB3 score, which is the worst type of score at the moment. Again, if you look at the patients having a post-neoadjuvant pathological staging, the scores correlated really well with the neoadjuvant staging, post-neoadjuvant staging in these patients. According to the site of clinical treatment, again, there was a lot of, all of the scores correlated really well with the EFS and DRFS data. So coming to the subtypes, they managed to show that each of the hormone negative, positive, HER2 negative, positive subtypes, again their frequency of the PATH-CR also correlated really well, as well as the survival data when compared to the RCB scores showed a good correlation. So if you come to the TNBC type, the PATH-CR achieved was 43% and the worst was 11%, that was RCB3. So the survival data matches really well with 86% 10-year EFS and 25% at the last range. When coming to the HER2 positive patients, again similar correlation, the survival graph separating out well and the correlation being to be good. This is again with the hormone positive and HER2 positive patients. Same thing in the hormone positive and HER2 negative patients. In the multivariate analysis, the RCB index value compared to all the other parameters that the patient had, including the T stage, the N stage, as well as the grade, between all of these, the RCB index value scored the best and it correlated the best. So the conclusion was that long-term prognosis after PATH-CR is now known to be the best prognostic factor. The prognostic association of this residual cancer burden score was generalizable across all subgroups. This could be standardized now as a pathological outcome or a pathological reporting, and this could allow us to actually score the patient according to the, give this patient a score and give a good prognostic index. Seems to be a promising score which can be developed in the future and could be applied across countries. The limitations on this data was basically it was from multiple institutions with different clinical methods, different handling of specimens. Since the score is based on pathology, this could be a factor which could modify the outcomes, and some data on this was calculated prospectively and some was done retrospectively, so there could be a little bit of bias. Thank you.